Assalamu alaikum. Myself Dr. GhulamUllah Lail, Assistant Professor Medicine and Allied, Consultant Gastroenterologist. Viewers, welcome to VTeach24. We are here to discuss the upper GI bleed, basically the GI bleed and approach towards a GI bleed. What is the upper GI bleed? That's approximately 50% of the admissions from the GI bleed are secondary to the upper GI bleeding. That is from the esophagus, stomach or the duodenum. 40% are from the lower GI bleed. Then one were from the rest of the 10%. Rest of the 10% are the obscure bleeding, that is bleeding from the small intestine. So how to differentiate between the upper GI, lower GI and the what management options are needed to be taken for the obscure bleeding, we'll be looking afterwards. So हम लोअर जीआई ब्लीड किसको कहते हैं? जो कोलन में हो रही हो प्रीडोमिनेंटली, जैसे एनस, रेक्टम और से लेकर टर्मिनल आइलियम तक. टर्मिनल आइलियम से ऊपर हो रही होगी कोई ब्लीडिंग या लिगामेंट सबट्रेट्स से नीचे हो रही होगी जो कि स्मॉल इंटेस्टाइन का पार्ट है, तो वो ब्लीडिंग होती है ऑब्स्क्योर ब्लीडिंग. सीवियर जीआई ब्लीडिंग किसे कहते हैं हम? That is defined as documented GI bleeding with hematemesis, melena or hematochezia or the positive Ng lavage accompanied by shock or orthostatic hypotension. तो कब कहेंगे सीवियर है? जब शॉक हो या ऑर्थोस्टेटिक हाइपोटेंशन हो. अगर ये दो चीज़ें हैं तो सीवियर जीआई ब्लीड है. अब आ जाते हैं हम what is the occult and what is obscure. Occult is a GI bleeding that refers to a subacute bleeding that is not clinically visible, that the one whosoever is having that bleeding is not been able to pick up that bleeding. Means he is not having hematemesis, not having hematochezia, not having the melena, but blood is losing, and that can be tested by fecal occult blood testing, FOB test. But obscure bleeding is a bleeding from a site that is not apparent after routine endoscopic evaluation with the upper GI endoscope and the colonoscope. Means that is not up to the second part of the duodenum, or from lower down if we are going up, that's not up to the level of the terminal ileum. That this small intestinal bleeding that is not routinely been seen by the endoscopic intervention, and that is called as the obscure bleeding. So for the obscure bleeding, the diagnostic entities are available, that is like push enteroscopy, like angiography, that is the CT angiography, etc., etc. But the upper GI bleeding, the potential cause of the severe upper GI bleeding is the peptic ulcer. That is the most common cause, and that accounts approximately 80% of all the cases with the upper GI bleeding. And in the most of the situations, the upper GI bleeding is self-limited, and the patients with the upper GI hemorrhage, even without a specific therapy, they may have self-limitations. But those who have the continued bleeding, mortality rate may be higher, may be up to 30 to 40%, but that depends upon the different variables and those the risk factors. There are a lot of the risk factors that needs to be taken into account when we are dealing with the patient with the upper GI bleeding or the GI bleeding. So patients with the or at the high risk of the continuous bleeding or for the rebleeding, that potentially can benefit from most of the acute medical, endoscopic or surgical therapy. So we are talking about which patients? We are talking about these remaining 20% of the patients who have had the high mortality. So we are going to assess these patients Continuous bleeding or rebleeding may happen in these patients, and they may be treated by the medical, endoscopic or the surgical therapy. Now in upcoming slides we are going to discuss what are the medical treatment options for the variceal bleeding, what are the medical treatment options for the ulcer bleed, and what are the endoscopic treatment options, and when to refer the patient for the surgery. But once patient is having history of the GI bleeding, will present in emergency department, and what you will be doing in this patient, in the patient who is presented with the upper GI or the lower GI bleeding. Once patient is presented with the gut blood loss, what are the options? The option number one is definitely the resuscitation, and we will perform the resuscitation and then follow accordingly. For the resuscitation, efforts should be initiated at the same time the initial assessment in the emergency department. We need to continue during the and this resuscitation not only needs to be taken in the emergency but needs to be continued during the hospitalization. So two large bore cannulas should be inserted, either 14 gauge or the 16 gauge IV cannulas. IV lines should be placed, so there should be the two IV lines, and normal saline is infused as fast as needed to keep the patient's systolic pressure higher than 100 millimeters of mercury and a pulse lower than 100 millimeters of mercury. But mind, we are infusing the normal saline, just not every patient whoever is presenting in the emergency with the history of the GI bleeding. Infuse saline when systolic pressure is less than 100 or pulse is more than 100, means patient is actively bleeding. So here you see the next patient should be transfused with the packed red blood cells, platelet or the fresh frozen plasma as necessary to keep hemoglobin greater than 7 grams per deciliter. And this is in general, but when you are dealing with a patient who's elderly, whose age is more, then you need to keep the hemoglobin levels slightly higher, up to 10 grams per deciliter, to avoid the patient to have developed the myocardial ischemia. Definitely. So as patient is presented in the emergency, you will assess the vital signs, in which the pulse, blood pressure, and then the respiratory rate and temperature, all four you will be checking. Once you have checked blood pressure, you will decide the normal saline as well, and on the presentation you have deployed the two IV cannulas, and you will send the blood samples for the hemoglobin, platelets, and you will arrange those things which are needed. If the patient is having anemia, you will definitely need the transfusion. So arrange and cross match the packed cells is necessary step one of the resuscitative measures. And platelet count higher than the 5,000, higher than the 50,000, or the PT less than 15, then we are not worried, and we have these set limits. We need to keep platelet count more than 50,000 and PT less than 15 seconds. In the patients, if patient is actively bleeding, an endovalian urinary catheter should be placed. Why urinary catheter? To assess the urine output, and urine output is an indirect assessment of the patient's proper blood flow and lack of the ongoing blood loss. If patient's urine output has decreased, means patient is going towards the renal shutdown. One issue is already there, that is the GI bleeding, and other issue is patient is going to develop, that is the acute kidney injury. What next? Resuscitation, the endotracheal intubation, that should be considered in the patient with the active ongoing hematemesis with altered mental status to prevent the aspiration pneumonia. And other is age more than 60 years, should be evaluated for MI. And once patient is presented, we definitely will go for this severity assessment. We have the M65 as an severity assessment, and then an M65 that is by the name A for albumin, I for INR, is for systolic blood pressure, and then mental status, and then the age, that is 65. One score for each, and anything that is score greater than 2, that means a score of 3 is high risk, and then patient will be admitted in the ICU. Similarly, there are some other scoring systems as well, like the Blatchford scoring system. See, in the Blatchford scoring system, we have variables like systolic blood pressure, like the blood urea nitrogen, hemoglobin, and other variables. And there are the scoring points on each variable. You need to know what variables you will consider. That is simple. That blood pressure, blood urea nitrogen, hemoglobin, pulse, presentation with melena, hepatic failure, or the cardiac failure. And then the total score. In most of the patients need the intervention if their score is 6 or higher. Higher the score, higher the chances to have an intervention needed. And another scoring assessment system, that is ROCAL system for the upper GI bleeding. Age, pulse, systolic blood pressure, comorbidity, diagnosis, and then the endoscopic intervention are the you see, every severity assessment scoring system has its own benefits. So while managing a patient, age is a necessary factor, and then systolic blood pressure, definitely. Almost all three assessment scoring systems keeps in mind the systolic blood pressure, then pulse rate. So these are the severity assessments. अब देखें, जैसे जैसे एज बढ़ती जा रही है, नंबर ऑफ पॉइंट्स इंक्रीज्ड है. और इसी तरह से कोमॉर्बिडिटी में देख लें, अगर रीनल फेलियर है, हेपेटिक फेलियर है, या मैलिग्नेंसी है, तो स्कोर 3 मिल रहा है डायरेक्ट. और एंडोस्कोपिक इंटरवेंशन में भी इसी तरह से है. अगर पेशेंट को अपर जीआई ब्लीड है जिसमें एडहेरेंट क्लॉट है, विजिबल वेसल है, या एक्टिव ब्लीडिंग है, these are the signs of the high risk stigmatas of the recent hemorrhage. If these are present, 2 points are scored. So overall the collective score is necessary. If collective score is pre-endoscopy collective score more than 4, patient is high risk, and post-endoscopy collective score of more than 6, patient is high risk. See, if there is 4, because of the age and some additional factors, pulse of more than 100 and systolic blood pressure of less than 100. See, score was 5 preemptively, but when we have performed the endoscopy, we have seen just Mallory tears, score added was 0. So even post endoscopy there was no change. Post endoscopy and pre endoscopy, the ROCAL scoring may be used twice, pre endoscopy as well as post endoscopy, and in this system we don't need any blood report, so that's why this is bit better on the bedside. I hope you have understood. Thanks.